Good evening, everybody, and welcome to this International Forum webinar on Doing More with Less, Reducing Waste and Improving Quality. We're thrilled to have you all with us here this evening and are looking forward to a really interesting and challenging discussion with our panelists. My name's Kyle Rolfe and I'm a Senior Conference Producer at the BMJ, and I'll be your host for today's session. So I'm just going to begin by taking you through the agenda and some housekeeping about the platform before I hand over to our first speaker. So today we've got a really interesting mix of presentation and discussion. We will begin with a presentation from Kedar, President and CEO of the Institute for Healthcare Improvement, following which we will have some time for questions. Kedar will then be chairing a panel with our esteemed colleagues, Dr. Girdhar, Gyani, Director General of the Association of Healthcare Providers, Dr. Anupam Sibal, President of the Global Association of Physicians and Group Medical Director of Apollo, and Dr. Arati Verma, Senior Medical VP for Max Healthcare. So we're thrilled to have all of our speakers here today and very much looking forward to their presentations. And I know they're very much looking forward to hearing your questions and your comments on their content. So just a few housekeeping rules before we move on to the first presentations. So as those of you logged in will see, you have access to see and hear everything in the session, but you won't be able to turn on your webcams or your audio. However, there's plenty of ways that you can get involved, and we would love you to do so we can make this a really interactive discussion. Firstly, you can type any questions for our speakers into the Q&A box that you'll find at the bottom of the screen. So please use this box for questions to the speakers. You can put questions to the full panel or to a specific speaker. And if you like a question someone else has put into the box, please do use the upvote function so that we know it's a popular question and can make sure it's put to the panel. We also have a chat box function, which I can see a few of you using to say hello. So please do use that chat box function throughout for any comments, anything you want to say to the group that's joining us today, and also any technical queries that you have for the BMJ team. We'll be moderating that chat box for you. And without further ado, I will then hand over to our first presenter for today. So it's my absolute pleasure to introduce you to Kedar, who is President and CEO of IHI, and will be taking through our first presentation today. So over to you, Kedar.
Thank you, Kyle. Let me just get my screen up here, and I will just be with you in just a moment. So hopefully you can, Kyle, can I just check that you can see this and see my screen?
Yes, we can see that perfectly. Thank you, Kedar. And can I just ask our other speakers to turn off their videos while Kedar is presenting? Thank you very much.
Perfect. Well, I'll also extend my good evening to all of you and my warm welcome to this presentation. It's a real pleasure. It's a real honor for me to be speaking to you today. As Kyle mentioned, my name is Kedar Mate. I'm a clinician at Weill Cornell Medical College. I'm an internal medicine doctor at Cornell. And I have spent the last 15 years of my career working for the Institute for Healthcare Improvement, IHI, based in the United States, but really working all over the world. And I've had the pleasure of working with the IHI in India on a number of occasions throughout the time that I've served as in IHI's leadership. I'm currently its president and chief executive officer, and it's an honor to be in this role to both serve the mission that IHI has of improving health and healthcare all over the world, and to work with this wonderful community of improvers and quality scientists and experts and scholars, some of whom you'll hear from today. So we face today, as you all know very well, a unprecedented global challenge, a challenge that we've never seen in our lifetimes, and hopefully we won't see much more of in the future. But we face this enormous global challenge of COVID. And that challenge of COVID has done several things. Not only has it changed this conference from what was an in-person event that we had hoped for back in July into this series of virtual meetings and what we hope will become in the future an in-person meeting, but it has also challenged us clinically. It has challenged our clinical muscle as an entire globe to cooperate clinically in a way that we've never seen before. It's challenged us operationally. Our health systems have had to revise policy, change what we are doing, change the way that we do things in order to protect our staff and protect our people in a way that we've never seen before. And it has challenged us financially. And it has challenged us severely financially, not only as a healthcare industry, but as countries around the world. Very briefly, here is from the International Monetary Fund and the World Bank, some data on that economic challenge. This is data from about just a few weeks ago, suggesting that the global GDP, the overall growth projection for the world, will shrink by almost 6%. It'll go from a positive 2.9% growth in 2019 to a negative 3% growth by the end of 2020. We're hoping for a rebound in 21, but a lot remains to be seen about what happens with this pandemic as things continue to stretch on. You'll see that the difference in impact is significant across the world, with the Eurozone and the United States, where I live, being very significantly affected. In Asia, where all of you are, or most of you are, things are a little bit different. You still have a positive GDP, and I've seen the projections in India, but there is significant reduction overall, even if it remains somewhat positive. So there is a very strong economic challenge that I think all of us express. This is across the entire economy. Within healthcare, we have a very specific challenge. So in healthcare, on the left side of the slide is essentially monthly expenditure on healthcare from 1960 to present. And you can see, broadly speaking, there's been growth in healthcare spending of somewhere between 2 and 10% per annum for a very long time, from one month to the next, from year on to the next year. In the last 3 months, we've seen a negative 50% growth rate in healthcare expenditure. So not only is the economy shrinking overall, but healthcare specifically is being hit hard, even at a time when the number of cases of COVID is expanding and the need for our services is growing. And that's this story. You all have probably seen some version of this graph or map. This is the latest from yesterday or the day before from Johns Hopkins University here in the US, just mapping. It's the global COVID tracking effort that's been going on right now. 20 million cases of COVID overall that we know about, probably 3 to 4 times more than that are actually present that we don't know about. And of course, then you see the distribution of those cases and the mortality, over 745,000 deaths at this point globally. This is a very significant challenge clinically for all of us. So in the face of contracting financial situation, contracting healthcare expenditure, we also have this rise in need for what we do, the rise in the need for how we might serve in clinical medicine. And so that gets to the thesis of this whole session. Ultimately, we have to do more. We have to take more care and provide more service with what is likely to be significantly fewer resources. We have to do more effectively with less. So that's a puzzle. And the question is, how will we do that? How will we do more with less resource? And so when I think about that question, and when IHI thinks about that question, we go back to the fundamentals of quality and how we might operate our systems, how we might operate healthcare organizations with quality principles in mind. So I want to introduce you, many of you probably know Noriaki Kano, but if you don't know Noriaki Kano, his work holds some clues for how we might do more with less. Noriaki Kano was a business professor and quality expert in Japan in the 70s and 80s, and he focused almost entirely on producing value. How do we do exactly what we are talking about here? How do we do more with less? Kano had 3 ways of doing it, and I want to take you through how I think that might relate to where we are today. What he called Kano 1, or what has become known as Kano 1, is seeing the waste in our systems and removing it, seeing the excesses and the challenges and the waste in our systems and removing those wastes. Number 2 was optimizing the efficiency of existing systems of work. And number 3 was creating new ways of doing our work, innovation, innovating new ways to create new value. And what he noted was that over time, innovations became the standard of care in our institutions. And so one example of that is if you think about a car, we would not operate a car today without brakes and a windshield wiper and a seatbelt. That's Kano 1 level opportunities. We now seek to optimize the efficiencies of our cars to get more kilometers per gallon of fuel or kilometers per liter of fuel. And we would do that in number 2. And there are certain features of newer cars like cruise control and ways of the cars can see things in the road and accommodate and make sure that they don't get into accidents, that are the innovations that are driving new value in our cars. So we have to think about how these 3 things will help us to create new opportunities and find new ways of working so that we can do more with less. Kano 1, seeing the waste. The good news here is that there is plentiful waste in healthcare today. This is data from my country, from the US, where we have shown in multiple studies, there have now been 3 separate government commission reports and 1 independent commission report that suggest that inadequate, unnecessary, uncoordinated, and inefficient care and suboptimal business process consume at least 35% and maybe more than 50% of our annual spend on healthcare. That is an enormous amount of money that we spend and likely waste today. That means that there is approximately $1 trillion in our economy alone, in the United States alone, that is being wasted. There is a huge amount of waste in our systems. And this is not just a problem at the macro level, at a whole system level like I'm showing you here, but it's also a problem in our clinical practice environments. And if I may, I want to introduce you to a patient of mine. This is not her name or her picture. This is just an image for illustration, and it's not her name. But this is a real patient that I've taken care of. I met her in the hospital in New York, but this is a real way in which we can illustrate that these wastes are happening not just at the country level, at the whole country level, but they're happening in our daily interactions with patients. So Nalini is a 68-year-old woman. She has hypertension and diabetes, and she's got new joint pain, and she was taking nonsteroidals, ibuprofen, to help treat her pain. Her pain wasn't getting better, and so she increased her dose. She did it by herself. She increased her dose. She started going from 200 milligrams to 600 milligrams to 800 milligrams of nonsteroidals. And ultimately developed, she didn't even know that she had some chronic renal insufficiency. She developed renal failure due to her diabetes. With the NSAIDs, with the ibuprofen, she developed some kidney injury, and that led her to become confused, and she fell and she broke her hip. She was admitted to the hospital, and this is where I met her in the story. She had surgery on her hip, but then post-operatively developed delirium, had a very long ICU stay, I think up to 14 or 15 days in the ICU. And ultimately, after a 20 to 22 day hospital stay, she was finally discharged to a rehabilitation organization in New York. And then she kept coming back from the rehab. She kept cycling back and forth to the emergency room and rehab for over 3 months. I saw her multiple times during this period of time. What I didn't know until somewhat later on was that Nalini had a husband at home, a 75-year-old gentleman, who she took care of. And that gentleman, who was now alone in his home, could not care for himself. And so he was ultimately admitted first to the hospital and then to the nursing home, as he couldn't manage his own chronic diseases at home alone. Unfortunately, her husband developed confusion and ultimately died in that nursing home. And when Nalini finally reached home, almost 3 months after this episode began, she was significantly debilitated and now on her own. You can see in this story how many, in the daily work that we do, how many wastes that there are, how many opportunities for improvement there might be, for getting ahead of her pain, for understanding her chronic renal insufficiency, for preventing these missed opportunities for coordinating her care better and getting it right the first time. The Japanese, just to go back to Japan for a moment, the Japanese and Toyota talked a lot about it. When Toyota installed its now famous production system, the thing that made Toyota so successful after World War II, Toyota mercilessly focused on removing waste. That was their way that they became, as powerful and as strong as an organization. They sought and identified 6 forms of waste, and they are all apparent in healthcare today and in the case of Nalini that I just illustrated for you. Those types of wastes are delays, time spent waiting for something in waiting rooms or waiting for a test result, patient bed assignments, OR preparation, etc. Rework, performing the same task a second time, getting readmitted to the hospital, getting rescheduled, retesting, repeat documentation. Overproduction, doing too much of healthcare, applying too much care, and in some cases, products and information that may not be needed. Precautionary defensive medical tests. Sometimes doing less is actually doing more. Movement, unnecessary transport of people, again, cycling back and forth, as you heard in Nalini's story, between the rehab and the hospital. That type of movement is waste. Mistakes, errors in medicines, and errors in how we do our work, wrong site surgery, poor clinical outcomes. Again, very a thread throughout Nalini's story. And then importantly, the waste of the spirit and the skill. And if I think about what's happening right now with COVID and the threat that it poses directly to our healthcare workforce, there is significant wastage of spirit, skill, and in fact, actual staff that we are losing in some occasions, thankfully, somewhat rare, but all too common right now. We are actually losing staff to the virus. So these are the 6 categories of waste that Toyota sought on an everyday basis to see and systematically eradicate. And I think if we can train ourselves as clinicians and as healthcare leaders to see these categories of waste, we will achieve Kano 1 and try and increase the value of our systems. The second level of the Kano framework for how we might improve value is known as Kano 2, or optimizing the efficiency of existing systems. 4 years ago now, our research and development team at IHI spent time studying various strategies for system optimization that were being used all over the world. And what we understood was that basically all of those system optimization efforts boiled down to 3 essential steps. If there was a care model that was non-standard, I'm talking about, a care pathway for sepsis, for stroke, for acute myocardial infarction, you name it. If there was a non-standard care pathway in your system, the first step was standardizing the care model. And when you did that, you could apply 4 simple concepts illustrated here in the green box that would improve the value of your standard care model. Simplifying the process, removing steps from the process, coordinating better care in the process, substitution of low-cost consumables or staff for high-cost staff or consumables, and increasing the agency of patients in their decision-making, because patients often choose, not always, but often choose the lower cost option when presented with multiple choices. Once you have a standard care model, you can then work to increase the efficiency and volume and throughput of that care model. You can optimize the efficiency of that care model. And when you do that, that will lead to excess supply of resources in your system. And then leadership has a clear and important decision to make about how to use that supply. They can either direct excess demand towards it, or they can decide to remove it from the system. We have applied this 3-step process now all over the world, IHI has. And I'm just going to show you some results from a handful of systems that demonstrate, from one system that demonstrate the value and the utility of applying this efficiency optimization algorithm, if you will, to their clinical process. Here's data from Qatar, from Doha, and the Heart Hospital. They showed, by applying the methods that I just showed you, that they can get better clinical outcomes in the cardiac ICU. This is just one of many, many, many clinical outcomes that they've documented. This is phlebitis in the cardiac intensive care unit. They showed basically a reduction from 15 to 17 cases of phlebitis a week down to 0 in their unit. They also saw more timely and early discharge. For those of you that operate hospitals, you know that timely and early discharge allows you to increase flow through your hospitals and increase throughput. And doing so translates into real economic value for your institutions. By applying these methods of simplifying, coordinating, improving decision-making, standardizing the care model, they were able to go from fewer than 10% of patients being discharged before 1 o'clock to nearly 100%. And ultimately, they had an impact on costs. This is just one measure of cost, the cost of consumable uses. They shrunk the cost of consumable use by 50% in this institution. We've seen overall costs for entire hospitals go down by 10 to 12% on account of using these methods in their institutions in different parts of the world. And we've tested this in Scotland, in Qatar, in Singapore, in India, all over the world now, and we see similar results wherever we go. So Kano 1, see the waste. Kano 2, optimize the care process. Kano 3 is innovation and creating new value where that value doesn't previously exist. And here, I think that there's incredible opportunities to learn together. My final trip before COVID broke in the world, and before all the moratoriums on travel and moving around, my final major trip was to India, and I was with our partners and colleagues, Aravind Eye Care System. Many of you will know Aravind very well, in South India and Madurai, for the better part of a month, actually, in December and January, studying their systems and how they've achieved such incredible progress in helping them to spread their approaches around the world. I was taken by this particular model, and I'll just, if you'll permit me 1 minute to explain. Aravind has partnered with Google, as some of you will know, to create new approaches to artificial intelligence guided retinal scans. And with using that technology and artificial intelligence, they've been able to correctly diagnose diabetic retinopathy 97.5% of the time. And these devices can now be placed in remote places throughout their catchment area in their service region. And that allows for us to get now state-of-the-art diagnostic capacity and capability in many, many parts of the country that might have otherwise not had the ability to get that. This is creating new value, and it's allowing us to make diagnoses, make interpretations, and treat patients earlier in their disease course, so as to potentially prevent disease progression and ultimately blindness. That's innovating and creating new value. That's leveraging technology to create new value. Another potential source of new value is the patient, him or herself. And here is four individual patients. None of these people, all of them have end-stage renal disease and are on dialysis. None of these individuals are trained nephrologists or even nurses. All of them are patients, and all of them are administering their own dialysis. I believe that we have grossly underestimated the capacity and skills and knowledge and abilities of our patients and of our family members themselves. If we were to leverage their knowledge, skills, and capabilities, they can do some of the things that you're seeing here on this slide. They can actually hook themselves up on a daily or weekly basis, or 3 times a week, to their dialysis machines, calibrate them, and operate them. And we've seen this now in Sweden, in the US, in different parts of the world. These are 4 patients from the Central Texas Nephrology Associates. And I show you these 4 because we have data from this setting on the impact of this. Not only, you can imagine that the cost would go down, the nursing ratios would go down, but you can also imagine this, and this is what's important to this, people that are on this self-dialysis, when compared to usual dialysis, had a 5 times lower mortality, and they were hospitalized 3 times less than patients that got dialysis the usual way. And that, to me, is the real opportunity when we talk about creating new value and doing more with less. Tapping into the power and knowledge and skills of patients, I think, a very important latent resource that we have not fully utilized. So, in summary, we have to do more with less. We have no option right now. We've always had to do more with less. COVID has simply accelerated the need to do more with less. To do that, we can see the waste and remove it. We have to optimize the efficiency by applying modern quality improvement methods to existing systems. We have to innovate by leveraging technology and, I think, people, patients, families, and others in new ways that increase value. And lastly, we've got to learn more quickly. My colleagues at IHI wrote a piece in the BMJ opinion section where we talked about what we've seen with COVID accelerating learning across boundaries, across organizations, across nations, and indeed across the world. To accelerate value, we not only have to get better at seeing, optimizing, and innovating, but we also have to get better at learning. So with that, I'll stop, and I'm happy to take your questions. And thank you once again for your time today and your wisdom. So, Kyle, over to you.
Thank you so much for that, Kedar. I think that was a fantastically succinct presentation that covered a range of different issues and different topics. So we're very grateful to you for sharing and excited to take some questions and use that as a basis for the discussion for the rest of this session. So thank you very much. There's been a few questions that have come into the chat, but if I could ask everybody to just put their questions into the Q&A box if you have anything for Kedar to answer. And I thought I might kick off with one of my own, if that's okay, which was just about the role of the patient. So you talked a little bit about how important that is in terms of sort of defining value. And especially in terms of sort of service users, and you talked about the renal example. Do you also see a role for the patient in a leadership role to do with this, sort of looking at sort of organizations from top down as well as that sort of service user perspective?
Yeah, I think, I mean, you know, there's obviously many ways in which patients are formally engaged in leadership councils. There's the sort of classic patient advisory council that is leveraged often as a strategy for health systems to access knowledge and wisdom of patients. But I actually think that that's the way we've thought about it for a long time. But I actually think there's a very interesting and important way in which patients add value to each other, not necessarily through the system. And if you think about platforms like Patients Like Me, I'm sure there's equivalent versions of it in India and the UK and elsewhere, where patients are actually talking to each other about how to live with their clinical circumstances and with their clinical situations. There's a lot that patients can teach each other about how to live with congestive heart failure, how to live with inflammatory bowel disease, how to live with ovarian tumor. That simply put, a clinician having never lived with those things for the most part will be challenged to help explain. And I think it's in those places that we haven't really fully utilized patient voice and patient knowledge and patient skill to help teach each other on some level how to better live with and face their clinical conditions. That's where I think the bigger opportunity lies than the traditional kind of interfaces with health systems today.
Absolutely, and that neatly leads on to a question from Dr. Thanka in the Q&A box, asking about sort of how we do a lot of these things when literacy rates are low. How do we sort of engage people when there's that barrier in place? But I guess that speaks a little bit to what you've just said.
Yeah, you know, it's a fantastic question, and I don't want to underestimate the challenge. So it's easy to say these things in a talk like this, and it's easy to kind of imagine it in theory. Obviously, much more challenging to actually get into the implementation of this and to actually tackle the challenge with a patient or with a group of patients together. But I wouldn't let that dissuade you, I suppose is the point. And it won't be right for everyone, you know, to be clear. You won't get every patient. You even saw in the Texas example that I showed you, only about 200 of the patients, 191, were doing the dialysis in this way, in the self-administered way. The vast majority, 590 of them, were not. They were doing it through the usual means. So only a certain subset of your patients are likely to be able to be capacitated and skilled and have the interest and will, frankly, to do this kind of self-administered dialysis. But if you can get a third, a quarter, even 10% of your population to start doing it that way, based on their skills, their literacy, their preparation, their abilities, that allows you to reduce your staffing ratios, to improve the efficiency of your service, to potentially achieve better outcomes in the way that we saw in Texas, et cetera. And you start to see an opportunity in that, again, to increase the value of the service overall, even if it's done heterogeneously at the individual level.
Great, thank you very much. To move on to a different topic, Dr. Pandey from Nepal is asking what's the role for investing in prevention and protection before we get into sort of, you know, the administration of healthcare, and how does that fit into the model?
Yeah, well, there's a whole other conversation that we talk about, that's how to go upstream and downstream from healthcare. You know, healthcare alone. I focus this effort on, or this conversation on, what to do within healthcare. But you're 100% right. There's a lot of opportunity, I think, to focus more upstream on public health and community health practices, to focus on prevention that would mitigate the need for more expensive clinical management in the formal healthcare settings. And I will say to you, and I'll refer specifically to the US, which is the area that I know the best, although I've had experience in other parts of the world. But here in the US, we have over the years divested. We have removed investment from public health and from community health resources over the last decade. And what COVID has done has basically shown us the lack of wisdom of that divestment. Having created a significant gap in how we fund public and community health here in this country, we do not have the infrastructure presently to actually do the kind of primary prevention and protection work around COVID. Now, there's other things, of course, that you can prevent and protect against, but I'm just focusing for a moment on COVID. And this present crisis has, I think, fundamentally exposed Dr. Pandey's point, which is that if we can't or we don't invest in that kind of prevention and protection, we end up wasting a lot more resource in the context of far more expensive care inside of the formal healthcare settings. If you think about Nalini, for example, in the patient that I shared with you, Nalini, if whoever her primary care doctor was had screened her for renal insufficiency because of her diabetes, they would have known to warn Nalini not to take high doses of ibuprofen. And we could have potentially avoided everything that happened after that. She wouldn't have developed the renal insufficiency, maybe wouldn't have fallen, maybe wouldn't have been admitted to the hospital and had all the subsequent challenges. So you are 100% right. And you know, that the old maxim of an ounce of prevention being far more valuable than a pound of cure is 100% right.
Wonderful. And another topical thing that's been mentioned by Dr. Amajit Gambhar from India, there's a lot of talk about artificial intelligence and its sort of benefits in creating efficiencies throughout systems. Do you have a view on that, and sort of can you say a little bit about some of the advantages and some of the limitations that you see in that space?
Yeah, you know, AI, I think is, you know, like a lot of things, and the reason I put it in this presentation, I think what we're seeing right now with AI, with the ability to process, you know, hundreds of thousands of images or pieces of data in seconds, and use AI to assist and guide clinical decision making and understanding. I think there's a lot of promise in this kind of overall. The challenge is how to integrate this into clinical workflows and work environments in a way that allows clinicians to actually do the work of being a clinician, you know, and not try to I think there's a lot of mythology around AI substituting for clinicians or somehow replacing. I don't think that's true. I think it's a matter of leveraging the knowledge that we might have now that AI gives us to actually do our job differently and better. And that integration point is the big challenge around AI, because we've got plenty of technologists that are busy developing exciting new things like we saw with the retinal scope. The challenge, I think, here is how do we get that into the clinical work environment in a way that allows us to really take best advantage of it and use it most successfully. So there's a lot of promised AI. A lot of that promise has yet to be realized. But I do think that in terms of creating new value, that figuring out how to leverage technology and integrate it into workflow is the challenge. You know, it is the challenge for all of us to figure out how to make that work more successfully, because then we get to tap into the brilliance of AI, the value of AI, and other such technologies. It's not the only one.
Yeah, wonderful. Thanks, Kedar. I think it's a really good point. I think a lot of people get very excited about the terminology AI, but there's actually a whole range of tools that fit that model, and I think a lot of potential there for sure. One final question I'll pull out from the chat, and then I'll ask you, if there's any questions you particularly want to answer before we move on. But Dr. Harish has asked, is there a place where there is a compendium or a resource thing that they can look through for models that may work in low and middle income countries? I know IHI has loads of resources there, so is there a particular resource center that you could point our delegates to for further information and examples of this?
You know, I wish I could say that there was sort of a consolidated place where such evidence-based tools and innovations were being gathered. In fact, we wrote a piece which has not yet been published about doing just that, creating an innovation aggregator that would place all of the COVID or non-COVID related innovations in one place so that people could access them, get guidance around how to implement, et cetera. But to my knowledge, that doesn't yet exist, and that's what we wrote about in this paper. Was that, you know, it would be nice if there was a global public good, a global public utility, free to use for anyone in the world, that was about aggregating, you know, all of the innovations that have surfaced in the near term as a result of the work on COVID, because there has been so much innovation due to COVID. And so it would be wonderful if such a resource existed. But to my knowledge, that doesn't yet exist in the way that we might hope for. So unfortunately, I can't point you to a good place. And if others on the line here know of such a resource, please put it into the chat or speak up, because there's only so much that I may not have exposure to it. And I welcome the other panelists to also chime in here.
Thank you, Kedar. I think this will we'll leave the questions there, but I just wanted to check if there was any other questions to the chat box you particularly wanted to reference before we move on to the next section. There will be an option if you'd like to. You can type answers to these as well as we go through. I think
we're good. We should probably move to colleagues now and just make sure we get everything in.
Wonderful. Well, thank you so much for taking those questions and for a really insightful and very interesting presentation. I'll now hand over to you to lead us into the next section, which is our panel discussion.
Thank you. Well, so wonderful. And I just want to say once again, thank you for your questions. Please keep them coming in. But let me now turn to our panelists, and I'll just briefly introduce all three of them together and then ask them each in turn to give their opening remarks. So the first, Dr. Girdhar Gyani, widely recognized as one of the founders of healthcare quality in India. During his tenure as Secretary General of the Quality Council of India, Dr. Gyani played a pivotal role in the formulation and operation of the National Accreditation Board for hospitals and healthcare providers. Now, as many of you know, NABH. Currently, Dr. Gyani is working as a Director General for the Association of Healthcare Providers of India, which represents the vast majority of all healthcare providers in India. So welcome to you, Dr. Gyani. Wonderful. Professor Anupam Sibal is the Group Medical Director of Apollo Hospitals in the group and a Senior Consultant Pediatric Gastroenterologist and Hepatologist at Indraprastha Apollo Hospital. Professor Sibal set up the first successful liver transplant program in India at Apollo and was appointed as Group Medical Director in 2005. He's also helped to secure the first international accreditation of an Indian hospital by the Joint Commission International. He's currently a member of the Asia Pacific Advisory Council to JCI and serves as an honorary professor of Makerere University in Sydney, Australia. Welcome to you, Professor Sibal. Dr. Verma is the Senior Vice President for Medical Quality at Max Healthcare. Her responsibilities include providing direction for delivery of ethical and world-class standards of medical care across the Max Healthcare enterprise through standardized protocols, quality assurance, accreditation, and statutory compliance. Dr. Verma is on the panel of NABH and serves as the Chair for Appeals Committee and Assessor Management Committee. And prior to this, she was in the UK with the Strategic Health Authority working as an Assistant Director of Quality, so she brings additional international experience to this. Welcome to you as well, Dr. Verma.
Thank you.
So with that, I'm going to invite, just in that same sequence, to give some remarks about the state of quality and the opportunity to do more with less. So let's go to you first, Dr. Gyani, with your remarks about this issue.
Okay, thank you, Dr. Kedar. And it is very, we must thank, BMJ and IHI to come and organize the event in India. We have been looking forward for such event for a long time, but somehow we could not do it in the past. Now, you see the subject of value-based care. I have been saying that for past 1 decade, we have been talking about value-based care. But for past 5 years, it is now gaining the momentum. And this COVID is going to really push it hard. But I'm wondering whether there is any opportunity for reducing the cost. Because I will tell you that measurement of medical outcomes has really gained a lot of priority in most of the developing countries, thanks to payers, pressure from the payers, thanks to pressure from regulators, accreditation bodies, and even model like clinical governance. So I think we have made really good progress in medical outcomes. But let me tell you, I think you are at the IHI, but same is not so in respect of measuring the cost. Unfortunately, I think we have been focused more on the clinical side rather than on the economic side. Now, let me bring one more point. That innovation, which is happening in healthcare at very fast pace, it is making healthcare capital intensive. And this has in fact introduced a race. I will talk about India, even must be true about all other countries, race among hospitals to acquire the newer technology and to project, okay, that they have upper hand over their competitors. For example, some hospital is managing very well with a 64-slice CT. Suddenly I found they have procured 512-slice CT machine. I was wondering how actually what is going to be the utilization. So this is one little aspect of that which generates the pressure on the hospital, and the model goes on return of investment. Instead of other aspect, the priority goes on return of investment. Now I'll give you one more small example. 10 years back, when I used to look at the operational cost in a hospital, 35% used to be the HR cost. Today, let me tell you, Dr. Kedar, you can ask my other two colleagues, it is hovering at 50%. 50% is the HR cost. This is one aspect, that's why I'm wondering how can we reduce the cost. Second is the only we can increase the value. That, of course, I am convinced there is a hell of a lot of opportunity for us. But what is happening now with this specialization which is happening now, the care is becoming fragmented on account of increasing complexity. In the same department, I find the two surgeons are doing the same procedure in a different way. So instead of looking the patient holistically, every consultant or every stage we are trying to look at it differently. So now I think that's why I think we have to focus on not only measuring both the clinical outcome, but also the cost at the patient level, not otherwise, at the each patient level. And if the better outcomes come, I am convinced that better outcomes overall will reduce the total care cycle cost. So instead of focusing only on reducing the cost, we can focus on outcome which is going to really give us the total same benefit. So my few key points here are eliminate the variance in the treatment. This is also one of the reasons why what we find that, you gave the example of Kano 2, that readmission or the errors happening. So this can be avoided if we can eliminate the variance in the treatment. That means giving the same standard treatment protocols among all our clinicians. Of course, we can eliminate the unnecessary processes which are not adding value. Improving the resource utilization by eliminating the bottlenecks. This, of course, can easily happen if we start focusing on this particular aspect. Then, of course, this is my also worry that we are not trying to optimize the matching of clinical skills to the treatment processes, depending on who is a clinician and which kind of patient should be given to him. And finally, we speed up the patient flow by reducing the cycle time. So 3 points, which are, of course, you are very strong in this area. To reduce the cost now, otherwise I'm trying to bring it, we have to bring the green practices. Electricity is the one area where really our hospitals are doing very well to reduce the cost. Lean management, hospitals have started working on it. Hospitals in a group are trying to set up common STP, ETP. And one more development has taken place in some of the smaller places, that common diagnostic centers, radiology and the pathology. 7 hospitals in that area I found had established one diagnostic and one pathology. It has really reduced the cost so much. Hub and spoke model by establishing the satellite hospital can be another model which is working very well. And finally, the supply chain again, if the 7 hospitals, which I am quoting here, they join together, establish one pharmacy, supplier, one laundry, one catering fellow, and the devices. So this kind of small measures have helped some of the examples which are happening in India to reduce the cost. So final mantra is, you may not be able to reduce the cost because of the capital intensive, business, but you can reduce the waste. And there is, as you showed in the first slide itself, there is so much of the potential is there. But value can be increased. And if you can increase the value, the cycle cost will come down, patient will be happy. And so this is the way I think value and the cost can be balanced. So this is from my side. Thank you very much.
Thank you, Dr. Gyani. This is very, very insightful and very helpful, kind of very focused on some of the key ways in which we can actually achieve that type of waste and reduction and improvement. Let me turn now to, we'll come back to you and others on the panel for questions in a moment. May I just encourage everyone that's on to please chat in your questions. We're seeing some of them come in the Q&A. You can use the Q&A or the chat function to send your questions for Dr. Gyani so that we can turn to them in just a few minutes. But let me now welcome Professor Sibal. Please come in here, Dr.
Sibal. Thanks, Kedar. Great presentation. We all admire the good work IHI does, starting with Dawn, and he sort of collaborated in the past and seen, the amazing difference you've made across the globe. And big thank you to BMJ for bringing us all together. So, world in the last 225 days has really changed. It's turned upside down, as we know, our personal lives, our work life, society, countries, the world. And I think this has given us time to introspect. It has given us time to think on how we might actually look at life differently, how we might look at medicine differently, and clearly find ways to be more efficient, more in keeping with what each clinician wants, which is, better outcomes for every patient. And what every patient wants is also about better outcomes and lower costs. So tremendous opportunities for us to analyze. And some of the areas that I think that we can look at right away. Now, each one of us, we're involved in very large systems, and we have, at Apollo, we have 10,000 beds, we have 8,000 clinicians. And one of our priority areas is making sure that our consultants, our junior medical staff, our trainees, and we have about 800 trainees, keep abreast of whatever is latest anywhere in the world. And while they subscribe to journals, one of the things that has been done in the past has been all these meetings and conferences, and in fact, sometimes way too many. But that means, traveling, it means spending time, it means huge amounts of cost for the venue, cost of travel, and so on and so forth. And what we've discovered is that, listen, we can do this. Now you're sitting in New York, we've got folks sitting in London, and we guys are sitting in Delhi, the three panelists, and we've got a whole lot of colleagues from different parts of the world actually having a pretty meaningful interaction, which is costing us nothing. So we can do the same for conferences. And in fact, we've been doing that effectively. And I don't know how many of us know, but there are 1.4 million physicians of Indian origin in the globe. And we established the Global Indian Physician COVID-19 Collaborative. We established it on 11th of April, and now we have membership from 49 countries. And every 2 weeks, we talk, we deliberate. Last week, we talked about demystifying diagnosis. Earlier on, we looked at all the data for the different therapeutic options. We've discussed complicated issues that have come up in COVID-19, and we have participants from Australia right up to Canada. And clearly, it costs nothing. So I think we're going to start saving a lot of money on physical meetings. So that's one short takeaway. It's going to actually keep us where we want to be in terms of knowledge, but with no cost. For clinicians, what is the most important thing that they have, which we need to conserve, and that's time. They can only put in that many number of hours at work every day, but we all know that there is wastage of time. The time between cases in the OR, time between cases in the cath lab, endoscopy, DSA, and so on and so forth. We know that sometimes when physical appointments are scheduled in the outpatients, the patient gets held up, or there's a parking problem, and there's a delay. So there are a lot of delays that actually consume the most valuable time that a clinician has to offer. And I think there are ways for us to be smart about it. From a patient's perspective, again, there is wastage. They come in and the doctor's not there, and there's wastage of time. And then they go in and they have to re-register for radiology and for labs and so on and so forth. And a lot of this can be done virtually at home. And I think what COVID-19 has taught us is that in a significant proportion of patients, we can deliver the same quality of consultation through a virtual consult. It saves a lot of time for the patient, a lot of inconvenience, travel time, especially if you're coming from another end of the city. And in our case, when we get a lot of patients from outstation, they come in to be seen by an endocrinologist who really could manage the dose of insulin and other medication virtually. So I think virtual consults are here to stay because they're beneficial to the patient, and they're also beneficial to the physicians because, you know, the turnaround time is much faster. I think there's an opportunity for us to relook at everything that we do, you know, starting from communicating with our patients to registration, to managing outpatients, to managing procedures, to managing admissions, to managing discharge, rehabilitation, follow-up. And I think time is going to be spent on how we can get more efficient and actually decrease wastage. And I think the Kano principles that you alluded to are something that are going to receive increasing attention in the days and weeks and months to you know, ahead of us. What COVID-19 has also taught us is to be smart about how we consume. You know, India didn't make any N95 masks in March. We really didn't have that many PPEs in the country. Today, India manufactures 550,000 PPEs a day. We're the second largest manufacturer of PPEs. But I think the initial phase made us understand that, you know, we need to be smart. We need to decrease wastage. We found that with PPEs, we found that with other materials, we found that with consumables, and I think that's here to stay. We're going to be smart about using stuff that we have to use in large volumes, and how is it that we can, without compromising quality, ensuring the same outcomes, actually decrease wastage. And I think tech is really going to transform things, because I think we've realized the virtues of technology. And if there was someone who had, you know, who felt uncomfortable with technology, I think COVID has made sure that that hesitation that that individual had about technology is gone. So I think we're going to become very tech savvy. A lot of healthcare interventions are going to become more efficient by use of technology. And I think we're just going to get smarter at doing what we do each day. Over to you, Kedar.
Thank you. Those are really prescient, I think, remarks, and congratulations on setting up that wonderful network of physicians around the world from 49 countries, as you say, that's learning together about how to tackle COVID with one another. Let me turn now to Dr. Verma from Max. And as Dr. Verma is coming on here, again, let me remind you to use the Q&A function to send us your questions for the speakers just now, or use the chat function. Thank you very much, and now welcome, Dr. Verma.
Thank you, and thank you for giving me the privilege to be here and share my experiences. I've heard a lot from my expert colleague panelists here. However, I'll take a different perspective and go into, you know, the practice of how we, as a case study of how we as an organization addressed our cost and waste initiatives. Of course, we defined our systems and processes. We have 14 hospitals with about 3,000 beds across North India, mostly in Delhi. And so we wanted to have standardization of care in many of our clinical and non-clinical areas, in fact, in all functional areas. So for instance, if a patient of acute MI were to visit any of our emergency departments anywhere, there would be a standardized clinical protocol to ensure there is a reduction in the variation. And we also use data to monitor how the flow processes are designed and implemented. We also then use that data to review the work periodically and find opportunities for improvement. So we reduce variation, we reduce waiting times, we improve clinical outcomes, we reduce our morbidity and mortalities around these clinical flow processes, wherever it is possible. So we've done that to a large extent, and we keep improving year on year. The other thing that we felt was that, you know, the systems are so complex that staff many times get overwhelmed by the flow and the systems, and they get engulfed by it. So they don't have a mindset to look at visible waste or ways of improving in their day-to-day activities. So we took up an initiative where we trained each of our departments, 2-3 people, on principles of identifying waste, identifying cost issues, and gave them training on lean and the DMAC part of Six Sigma, the first level. And then we use their help, because they are the process owners. We said, you identify opportunities where you can reduce waste in your areas. So changing that mindset was very useful. It also became a frontline led exercise, and therefore the scope of improvement could spread across our organization. So it wasn't just management driven. So we got involvement of all the people at the front line, the functional, middle managers, the HODs, to start looking at opportunities to reduce waste, whether it was a clinical area or a non-clinical area. Now the leadership was driving reward and recognition programs for this. So we had an organization-wide, people submitting their projects of what they've done, and then they were given a chance to showcase all their gains. And there was a huge reward and recognition program, which is done once a year for the staff with the huge audience, and that's a huge motivating and incentivizing, process. It also helped us share data and best practices from across our units and, cross-learn between each other. So that's the way we approached it. Every year, I don't want to exaggerate, but cost is a very important imperative, more than ever, after the COVID, of course. But it has always been so in our organization, because we are a private healthcare and we have to be accountable to our patients in terms of being cost conscious towards them. We have to be accountable towards our stakeholders who are our investors. We need to also save. There are very few, very low margins of profit in high-tech healthcare. And we need to have money to be able to upgrade our equipment, to build more facilities. So every possible way that we can be efficient in our systems, reduce waste, reduce cost without compromising quality, but in fact improving quality, we don't leave any stone upturned. We have had more than 100 projects of cost control in possibly every area, whether it's housekeeping, whether it's even like we've done an example of how many times a patient is pressing the call bell and asking, and what are the things that they're asking for repeatedly? How can we reduce this? And we found that simple things like a pajama for a male patient was not readily available on the floor. And 20% of the calls had to be made and people had to rework and get all those pajamas from the main store and stuff. So we changed our stocking mechanism and made these readily available near the patient rooms. And that saved us a huge amount of time and human resource. So we've done more than 100. Some of the very important ones that we feel which have impacted our patients also is, our antibiotic consumption patterns, where we found that our DDD rates have really dropped down to more than 30% than what they were before, because we monitor our antibiotic consumptions, and we have a very robust antimicrobial stewardship program, which is led by our clinical teams only. We have been able to reduce our readmissions and return to OTs as a form of, waste management and reducing errors. There's a very strong effort on, our patient safety and all the mistakes that happen in the organization. We have had issues where we found, we've been able to manage newly acquired renal failure in patients who are hospital-acquired renal failure. And we found that how can we reduce their length of stay, the cost of dialysis, and of course the morbidity and mortality, where many of these could have been prevented. So even from a patient's perspective, the waste is most unwelcome. And even from the organization's perspective, the waste is, we have most unwelcome. We have also been able to improve efficiencies by reducing the length of stay in the ICUs. So those are some of the thoughts that I have to say about how we have gone about it.
Well, thank you very much, Dr. Verma. This is very, you've got a number of initiatives that you're chronicling here that I think are really exciting to understand and to see. So I see that there's some questions coming into the chat, into the Q&A, and as those start to come in, I'll start to direct some of those to you. But I'm interested to hear, if I could just start by inviting you to consider, and if I may start with you, Dr. Verma, for a moment here. You've sort of outlined a number of different strategies that you've been using over the years for, improving quality, reducing cost. One of the things that Edwards Deming said, one of the founders of the quality movement, is that improving quality is the mechanism to reducing cost, not the other way around. It's not about just, frankly, cost cutting, because that's likely to create other rework or deficits or problems that may end up causing problems. But I wonder for you specifically during this time with COVID, have you seen any in your work? Can you give us an example of something that you're doing specifically now during the COVID time that you think are enhancing the value or improving the cost proposition right now? And if I could just ask others who are, if anybody is on that's unmuted, please keep yourselves on mute while we're having the conversation.
Yeah, so I did give a thought through to this, Kedar. However, I must acknowledge that you know, the COVID sprang on all of us, and we had to have a very rapid response of readiness, and the kind of investments that the organization committed to get our hospitals and teams ready in terms of PPE or you know, creating new ventilation systems for our wards, because we had fully designated COVID hospitals. So we had a huge investment. So I don't think our mindset was around efficiency and cost. It was about getting ready to receive our patients. But on hindsight, so I don't want to look at those 6 months that have been, you know, our P&Ls have gone crazy. And I don't think we'll be able to ever recover that part. But on hindsight, as we've grown and evolved, we have found certain things which have helped patients more than us. And it's the right way. We have to be conscious about the value that we're giving to our patients. Some of the things is, of course, reducing hospital visits for our patients. We've had a very good experience. Earlier, everything was face-to-face, and virtual consults was just not acceptable, neither by the patient community nor by our clinician community. Now we have more than 20% of our hospital consults going on as virtual consults with huge satisfaction levels on both sides. So that was a delight that we found. It reduces traveling time, and it improves the convenience for our clinicians. Of course, where a face-to-face is required, it is required. So that has been a very good gain for on both sides. Reduces our traffic rush to the hospitals. The other thing that we have found as a good outcome is home care services. A lot of our patients are now happy to take home care. And in fact, even in the COVID facilities, all mild to mild cases of COVID, which are 80% of COVID patients, are treated at home. And we have a virtual package where a doctor talks to them every day. We give them a kit, you know, to do their oxygen monitoring and, you know, ask about their vitals. And there's a nurse who follows up with them. So that has come as a huge comfort and reassuring part to for our patients, that a lot of them are, instead of getting hospitalized and then, you know, staying cut away from their families, they are actually getting better in their own home environment. It's cost effective, it's satisfying, and it's clinically effective. We've had absolutely no issue with this. And most of our patients are now you know, being treated in home care. So that's one of the things that have been really, so now we are looking at more options of improving home care for services in non-COVID areas. For example, in India, we don't have so much of home chemotherapy or home dialysis or other services. So now we're looking at how to enhance value for our patients by enhancing more home care services and keeping them out of hospital. So that's one thing. And this very, very easiest and simplest of things that we've learned, of course, which we never used to do earlier, was the namaste. We stopped shaking hands, and our greetings are now contactless.
Ah, yes. Well, that's it's a good example of how to do it right in this present time. It's interesting to think about the home care. I wonder if I could just Professor Sibal, I wonder if you're seeing a similar thing at Apollo. What are the kinds of innovations that you're putting in place right now in your system? If I can ask Professor Sibal the same sort of question that I've asked Dr. Verma here. What are you seeing that you think you might carry forward beyond COVID and perhaps apply to other clinical conditions going forward that you think might be value enhancing services for your patients and for their families?
Sure, Girdhar. I mean, clearly the learnings from COVID are going to be extrapolated to other specialties. So in terms of COVID, I think what we did, which we will take forward, is that, you know, we're a very large network. We have 73 hospitals across the length and breadth of the country, 100 odd clinics, 3,800 pharmacies. and about 900 touch points in labs. So very large workforce, and we needed to get everybody on the same page. So what we did, we really emphasized teamwork. So, we had one team that was just looking at infection control, one team that was looking at labs. How do we scale up, from zero to, we became the first corporate lab to be accredited for RT-PCR, how to scale that up. We had one team that was just working on plasma, one team that was working on clinical protocols. So clinicians across 8 major metros were working on reviewing every single paper. And as you know, there are 172 papers published every day on COVID. When we started, they were like 5 a day. Now we're like at 34,000. So by the time we finish this session, there would be 10 peer-reviewed papers published on PubMed, which is not possible for one human being to review. So we've changed our protocol 24 times for COVID. In fact, we do it once a week, but we had to do it twice when the recovery trial data showed that steroids help. So in the middle of the night, the moment the data was published, the next morning we changed the protocol and made sure that everybody was adherent to it. So teamwork, getting clinicians on board, virtually connecting them. You're not going to have these physical meetings. It's not possible. It would never work. They can meet at 11, they can post their comments, we, review that. So that's very important. The second thing we learned is the importance of clinical pathways. For COVID, we needed that. And here, everything had the potential of changing, and it did change. In other specialties, things are not going to change so frequently, but I think the learnings from here are going to be used across specialties. And, we do something like 1,400 solid organ transplants a year. So, there are lots of transplants, more than anyone else in the world. So, we need protocols that we need to constantly update. And I think the learnings from COVID are going to apply there and elsewhere. The other thing we learned is using AI. So, we did a fair amount of analysis we looked at hundreds of parameters for COVID, from age to demographics to comorbidities to, the clinical presentation to what happened to their LFTs and TLCs over a period of time, what happened to their X-rays, what happened to ferritin, and so on and so forth. So we've working on an algorithm that is going to help us prognosticate. And I think the learning there, we're going to extrapolate and use that elsewhere. We initially, when people were so petrified, we developed a COVID scan. You could do it at home, saying what is the likelihood of you actually having COVID, because everybody thought they had COVID, for the first few weeks. 18 million people downloaded that app. So clearly technology, how to really reach out, how to change, how to adapt, that's something. And, we've been very passionate about measurement of outcomes. We started that 15 years ago through a program called Apollo Clinical Excellence. So we measure outcomes, we actually put them on the website, somebody coming in knows what the chances of survival after a cabbage is. So I think we're going to focus more and more on outcomes. And I think by decreasing wastage, working smarter, I think clearly we will become better. And I think COVID has given us the opportunity to really look inwards, which perhaps we did not have the time for, or perhaps we didn't realize the potential that there exists. Over to you, Kedar.
Yeah, it's so interesting to think about the pace of learning during this time and the way in which you formalize strategies for integrating evidence into your local treatment protocols and in such a rapid cycle and aggressive way. It's a brilliant way to think about it, and it makes you wonder whether or not you can do this. Obviously, the pressure to do this and the need to do this in a public health emergency is very strong. But how do you take this forward into stroke protocol, where the publication rate isn't quite as, you're not getting 172 papers every day and not 10 papers every hour, but you're getting, there's certainly enough volume of literature and so on that's constantly evolving. So setting up that kind of clinical governance, I think, in the post-COVID era is probably going to be quite different to what clinical governance looked like in the pre-COVID era. If I may turn to you, Dr. Gyani, just for a moment and ask you a question about virtual. You spoke a little bit about this notion. I think all three panelists have spoken a bit about virtual technologies and ways of interacting with patients differently right now. All of the hype is positive around this. Even all three of you have talked about all the upsides of the virtual interface, and I can tell you that I've experienced it, having had a virtual visit, and not having had to sit in a waiting room was a relief, to be honest with you, and being able to do my work while I waited. But I'm curious, from your point of view, what are the risks here of virtual visits and virtual technology and telehealth? what might we be seeing here that we're underestimating right now from your point of view?
You see, if I recall my earlier days, that pilots used to be trained on simulation. That was the earliest example of using the virtual technology. Then in 2016, if you remember, the Dr. Shafli Ahmed, he live streamed the surgery in 360-degree with the augmented reality. Actually, that really drew the attention of people that this virtual technology can be used so well, particularly in the training. And that is being now used not everywhere, but somewhere in the medical colleges. Now coming to, let us say it is so good for a surgeon. Now he can actually prepare for a surgery. He can walk through the surgery, through on the 3D model. Our, physiotherapists are using in the pain management, the virtual technology. It is being used in the pain management also, particularly the stroke patient. Actually, it is shown the fantastic results, this virtual technology, combination of the virtual reality and the augmented reality. So these two things together are going to have a big say in time to come. Now, I don't see much of the problem that some people keep saying that it will cause radiation hazard among the people. Data security is going to be the key issue through this virtual reality. So these are the few things which I see as a disadvantages. So otherwise, virtual technology has all the advantages, and overall, if you see, which I gave the example of surgeon, it is going to reduce the cost. If you do all this simulation before actually laying your hands on to the patient, there is no chance of any error or any mishap in happening. So I think this is going to reduce the cost in a big way, and the risk is only that data security, which I think can be taken care of.
No, thank you. Well, there's some questions that are coming in now, and by the way, I'd encourage if anybody else wants to respond to any of these questions, so please feel free to chime in on other questions, Dr. Verma, Dr. Sibal, and Gyani. So the one question that's coming in here, I think that's quite an interesting question, is from K. Srinivas. He's asking a question to you, Dr. Sibal, about cost cutting during a time like COVID. And I wonder if you could speak to this question. The questioner is asking about, during a time like this, are we reducing salaries for healthcare workers? And Apollo has managed some strategy around cost reduction that may be replicable across the country, that's gotten some notoriety. Could you shed a bit of light on what's happening for you?
Sure. I mean, obviously, with the kind of pressures that each one has been facing, I mean, there are huge fixed costs. So we did have to look at what is it that we can save. And this was an exercise that we started in early March. We identified, I mean, travel was a huge expense for us. Travel within the city, travel outside, travel overseas. So overseas anyway stopped. Domestic travel also was virtually cut down. Local travel as well. So, all these conferences and all that was a sizable chunk for us. We made a decision on day one, and the promoter family and the leadership made a decision that no salaries will be cut for anyone on the front line. So, no doctors, no nurses, no housekeeping, no technicians, anyone there, would not have a cut in their wages because, one, they were frontline, and two, their wages needed to be protected, and we did that. I think that was something which was which received a fair amount of recognition from the team because they felt that we were attaching the importance that we should have, and we did that. We also started looking at wastage, and we've discussed this. You talked about it, Dr. Gyani talked about it, Arati talked about it. We looked at wastage at every step. We were judicious in our use of PPEs. We looked at our inventory management because, when you run a very large network, you can have a large inventory, and, that means money blocked. And we knew that the volumes are going to go down. So that is something that we addressed in terms of how is it that we can cut down on that. Obviously, no major equipment was going to come in because, the airports were shut. So, there was some amount of saving there. So I think all of this put together resulted in saving, and this was very important and it was needed.
All right, that's very, very useful. Dr. Verma, I wonder if I could turn to you to answer a question that's coming as well from Mahip Singh. It's about stress and I mean, obviously the workforce, I think, has experienced this in such a profound way, not only because of the direct threat actually of exposure and illness, but also just watching the challenge unfold clinically. What's your approach? What has been the approach to managing your staff during this time?
Yeah, it was an anxiety, I think, that we felt about how frontline staff are going to be able to deal with this. But surprisingly, we found that majority of our teams, they were quite willing to jump into the trenches literally and fight the battle. And what helped was, I think, from groups, they became a tribe. So there was a lot of peer support to each other in, PPEs, guiding each other, helping each other when they're tired. We also kind of encouraged a buddy system amongst themselves, so one person helping another and guiding them if they have some issues, talking about it. Our HR teams, shifted from being managers to coming and, interacting and waiting and talking to the teams when they were going off duty. We offered them a lot of services, which again, as I said, our cost structures went, and everything went haywire. But we opened our doors in every possible way to offer support to our teams. So if a nurse or a doctor did not want to go home to stay, after their duty is over in the evening or early morning after a night duty, we offered them accommodation in a 5-star hotel at our cost, with full meals and everything possible. We instituted additional time offs for them after they, got off their duties, and said that, okay, if you've done 10 days, here's 1 week off from us, just go relax. And once they have gone off the shift of a rota, say of a week or 10 days, they would not be posted back to a COVID area. They would then go back after their rest. And if they were not in quarantine, of course, if they had exposure, then they would finish the 2 weeks quarantine in our centers. Then they would go back to their routine work. So I think, all that has helped and is continuing to help us. We've not faced any major problem. We've also had some stress management classes organized by our HR department on call, and a helpline that if you're feeling stressed out, you call and we'll speak to you and we'll arrange a clinical psychologist to guide you on that. If you're feeling too stressed out and you can't do this particular work, then we're going to get you off this. So I think the support that the organization gave, the empathy that we gave, helped them, helped a lot. We've not faced any challenges. And of course, as Anupam has also pointed out, they have got not only the soft services and care, but not all their salaries have been protected. No, even though our non-COVID hospital services went down to 20% from 100%, our occupancies dropped because patients started staying away. We have not made any staff feel they are redundant. So we've held on to our teams through the pandemic. So I think they have also realized that it's a two-way process, and they feel attached and engaged, and they want to help out. Inherently, they want to help out and participate.
And I'm curious now, if I could ask you and anybody else on the panel as well, have you seen your volumes return now, your non-COVID related volumes come back to the hospital, or what's the experience been lately? Have things changed?
Huge return.
Yeah, okay.
We're back.
And Dr. Sibal and Gyani,
yeah, it's coming back, and it's because we're across the country. So if suddenly Bangalore goes into a lockdown or Kolkata goes into a lockdown and people can't come, so we see those regional variations. But Delhi definitely works increasing. Chennai works increasing in terms of people who've held back on care, which they was just too afraid to avail of, is now coming back. And I guess in the next couple of months, we'll see people making the right decision in terms of not delaying care further.
We found that critical care demand has suddenly surged, so ICU beds were the first to start getting filled up. Mm-hmm. And we're finding a few post-COVID morbidity is also coming back with fibrosis and all that, so some of that, but the routine non-COVID care is coming back very fast.
Yeah, you see, I don't think we are going to 90%, but from 20%, average is 50 to 70%. No, I'm talking about average of India. From our members, the percentage of IPD now has gone to 50 to 70%.
Yeah, ICUs are full, but electives are still trailing behind. They're picking up.
Yeah, and that begs a question, right? About, again, going back to the potential sources of waste in our system. One of them is overtreatment. And it's a hard one for us to wrestle with, I think, as a clinical community, because we think that most of what we're doing is necessary and important to do. But at least there is some part of what we do that is likely to be perhaps discretionary or may not be absolutely necessary. But it does touch on this question of when we're really pressed to figure it out, what is the absolute must do, and there may be some things that may not be. I do want to invite you now to each of you in turn consider a final statement here, but there's one question that's in the chat that I think gets to a meta point about this entire thing, which is we have this sort of general challenge in healthcare. We've had it for 100 years, which is that every time something is discovered, it increases the cost of the overall way that we do our work. So whether it's a new medication or a new diagnostic technology or a new robot in the surgical suites, or indeed a new AI guided retinoscope, whatever the technology that might be present, there's a price associated with that we pay to acquire that technology and then to integrate it. And BR Pandey is asking a very prescient and important question in the chat about how modern healthcare in any country, in any place, can be made more affordable when we know that technologies as they come in are quite expensive and challenging for us to sometimes afford. So in your closing comments, as we come to the end of this time, I wonder if you may comment on anything, but I also wonder if you could maybe comment on this question about how we should, as societies and as countries, wrestle with this challenge of how to manage the cost of something that we desperately want, which is the development of new technologies, because that makes us all healthier and better over time.
Yeah.
So let me just turn. Go ahead, Professor Sibal.
It's a very important point, and I think the world economy, the global economy, has kind of decided that. There is a investment that technology entails in terms of developing technology, whether it's new drugs or vaccines. But clearly, the price points of the past are not really going to work. It's just not going to happen. I mean, we've seen that. And especially for the low and middle income countries, the price points are going to be very different. I mean, look at remdesivir. Look at cost of remdesivir in the United States versus remdesivir in India. I mean, you see when the vaccine comes out, what the price will be in Western Europe and North America, and what will it be in India. So clearly, I mean, there's going to be a fair amount of adaptation. That it's going to be about volume versus, how do you actually offset the development costs. So I think that already is going to become more and more relevant, because there just isn't going to be enough money around. So, people are going to be very frugal about how they spend the money. Also, I think Indian innovation, I think it's great for Make in India. I think our Prime Minister is talking about PPE is an example, ventilators an example, Indian vaccine against COVID is an example. So we're going to see more and more of these happening. I think, this pandemic has made sure that our techies and our doctors started talking to each other. Taking outside healthcare getting in, and we saw that with PPEs, we saw that with ventilation. So I think this is really going to be very positive. And as I close, we all read the book Love in the Time of Cholera by Gabriel Garcia Marquez, and we are now actually going to be living in the time of COVID. So life in the time of COVID. And what is that going to be? Well, it's going to be about social vaccination. It's going to be remembering SMS, which we remember all the time, but it's going to be about social distance. It's going to be about masks. It's going to be about sanitizers, using hand washing, soap and water. And also in healthcare, it's going to be about NVT. N is it needed or do we want it? And we as clinicians really have to think about it. We want a lot of tools, but do you need them? So it's going to be need-driven, not want-driven. The we is going to be about virtual. It's going to be about virtual consults, virtual reporting. It's going to be about virtual meetings. It's going to be about virtual learning. And And of course, last thing is that tech is going to rule. And we're going to see healthcare become more tech centric than it was pre. Thank you.
Thank you very much. Let me go to Dr. Verma next. Yeah, please go ahead.
Just a quick thought on this. You know, like you have so much of funding which is welfare oriented for vaccine development, you know, the Bill Gates Foundation and what have you are willing to fund as a social gesture. Technology platforms should also be hugely subsidized so that the cost of development and the investment is not just for profit. So the patenting and issues, I think that will help overall at a global level to reduce the cost of purchasing ultimately and reduce it.
Thank you. Any final comments from you, Dr. Gyani?
I will only say, you know, this coordinated care is going to come in a big way, which actually we have not learned in the healthcare the way it has been happening in, let us say, automobile industry. Overall life cycle, patient life cycle cost also will come down. And let me also quote your own example that in the quality cost, you keep telling us that once you increase the investment on the prevention, then the final quality cost will come down. So I think same thing is going to happen in the healthcare. And we have started this experiment, but rather late. So this is the only way to ultimately, because investment has to go up in healthcare. You can't control that. If you have the good outcomes, you can't reduce the investment on technology. The only way is the coordinated care, reduce the overall patient life cycle cost. That is the way it will be done.
Well, thank you very much for that as well. And if I may just say, please join me. Let me just add my thought on this, which is that I personally believe that we must accelerate the development of technologies, because these are the very same things that have extended life expectancy by over 30 years in the last 100 years. So the development of the technologies and the extension of the technologies is very important. The question for us is, how do we ensure that the cost of applying those technologies doesn't bankrupt us, our social systems in our countries over time? And that, I believe the secret to that is the rigorous application of quality implementation methods. So the way that we apply the technologies and to get the benefit of those technologies is only realized if the actual, if the drug gets to the receptor, if the technology gets to the patient, and that requires rigorous application, which requires the quality sciences that we all have studied and become experts in. So with that, a final comment, please join me in thanking this wonderful panel. I know we can't hear the applause, but I'm clapping over here for all of you. And I just want to say thanks to everyone for joining us. Thank you to the audience as well for joining us here. And let me now turn it over to you, Kyle, to close us out and again, take us to the end.
Thank you very much, Kedar, and to our panelists for a really insightful and challenging discussion. I think a lot of themes in there that we'll all be thinking about for some time to come. So I just want to close the session by saying thank you again to our panelists, to Girdhar, Gyani, to Anupam, Sibal, and to Arati, Verma, and to Kedar Mate for their presentation and for leading us through that discussion. I also want to say a massive thank you to all of you for joining us. Your questions have been incredibly helpful in shaping this discussion, and we look forward to thinking about how we move these discussions forwards. This is also the final one of our series of 3 webinars that we have done. So just want to say again a huge appreciation for everybody for joining us in this new venture. It was something we did because we weren't able to meet face-to-face in New Delhi, but I think it's been a really exciting opportunity to open up some really important themes of discussion and something that we hope to continue. So we are hoping to bring the International Forum to India in the not too distant future, obviously pending the circumstances. So do check our website for latest details about that. And in the meantime, we'll send you a survey to fill out from this session. And we'd love to know what you thought about this session and also the previous ones if you joined those, and any ideas you have for future topics that we could cover. So with that, I'll say thank you again to everyone, to our panelists, to everyone that's joined us this evening, and I'll say good night. Thank you very much.